Good evening, everyone. We have been discussing how to evaluate a child for possible congenital heart disease. And as all of you know, one important aspect of evaluating a child is auscultating the child. The reason why I kept it separate was first to emphasize that it is not auscultation that necessarily brings on a diagnosis. For instance, we use pulse oximetry in a newborn. Mandatory pulse oximetry screening will give you much more information than auscultating a baby. This is not to underplay the significance of auscultation, but to highlight the fact that examining the baby altogether, especially using technology like pulse oximetry, is as important or more important than using our stethoscope. The session has been labeled as murmurs. I'll of course come to murmurs, but once again, I would emphasize on murmurs in the end and highlight that listening to the heart sounds is as important or more important than listening to murmurs while looking for heart disease in children. So auscultation involves evaluating the heart sounds. By heart sounds, we mean the first heart sound, the second sound. The second sound would involve appreciating the split of the second sound. It's not heard in the first few days of life. It's heard from the later part of the first week of life. And once we have appreciated the split, we would also focus on the relative intensity of A2 and P2. Then we would see whether there is any third sound or a fourth sound. It's obviously easier to hear that in an older child. And any additional sound like a click, an ejection click, a phasic ejection click of pulmonary stenosis, a constant ejection click of bicuspid aortic valve, these are additional sounds that we make out. And then we also look for murmurs. So it is heart sounds S1, S2, then additional sounds S3, S4, and then abnormal sounds like clicks, and then only murmurs. Please don't be put off by this diagram. There is some merit in looking at this diagram. What we have shown here is a very common physiology diagram. You can see the pressure rise in the left ventricle. You can see the first sound marked here. Note that the pressure rise in the left ventricle follows the first sound. After a while, the aortic valve opens, the ejection occurs, the rapid ejection, the slow ejection, and then after protodiastole, the second sound is inscribed. And following the second sound, the pressure in the left ventricle is dropping rapidly as it is in diastole. So the first sound times with the onset of pressure rise in the left ventricle. The first sound also times with the peak or the QRS complex. So the first sound times with the QRS complex. The first sound times with the beginning of isometric contraction. That is what we mean by saying that the pressure rise is beginning in the LV. It is after a short while, that short while being isometric contraction, that the aortic valve opens. This is the reason why if there's a murmur across the aortic valve, it can't begin with the first sound. It has to wait for an interval after the first sound. And this interval is the isometric contraction. And whatever we say for the left heart, you can transpose it to the right heart and say that if there is a pulmonary stenosis, the murmur will begin an interval after S1, which is the isometric contraction. It will also end before the second sound because the ejection, the rapid ejection is in the earlier part of the ejection. With the slow ejection, the ejection is rapidly decreasing. And therefore, the second sound will occur an interval after the first sound. Then the third sound and fourth sound, the third sound has to occur in diastole. So as the pressure is dropping in LV, the mitral valve opens and It is after opening the mitral valve a short while later that you get the third heart sound. And the fourth sound will time with the atrial contraction. So this shows in the lower part of the trace, you have the atrial pressure trace, you have the A wave, then the V wave. The V wave slowly rising up and then coming again, it decreasing as the A2 opens. The coincidence of these different heart sounds in different events of cardiac cycle is something that we need to know. That S1 happens with the onset of the pressure rise, that ejection systolic murmurs happen after the isometric contraction, the ejection systolic murmurs end before the second sound, the third sound occurs after the valve has opened in diastole, and the fourth sound occurs just before the just contraction, next contraction, and the peak of the QRS times with the first sound. With that introduction, let us recall that the heart sounds are caused by the closure of the AV valves or the semilunar valves, depending on which you are dealing with. We do not believe that they are caused by the closure, that the mechanism begins with the closure of the valves, there is no doubt. But the actual sound is produced by vibrations that come differently. I'll come to that in a second. And we have already said what it coincides with the end of diastole as marked by the QRS complex. It is before the carotid upstroke. It's a high-pitched sound. So you hear the first sound best with the diaphragm. And most of the intensity of the first sound is from the mitral component. Maybe 20% of the intensity is contributed by the tricuspid component. And the mitral and tricuspid components are close together. Human ear does not appreciate two sounds as separate if they are not separated by an interval of at least 30 milliseconds. And the normal interval between the two components of the mitral valve is only 20 milliseconds, and therefore you don't recognize any split. If you do recognize a split, that means the T1, the tricuspid component, is audible, and therefore that will be the split will be heard in the tricuspid area. What causes the sound is the sudden deceleration of blood flow following valve closure. We said the valve closure is certainly related to the genesis of the sound, but it's not exactly the valve clasping against each other and producing the sound. The vibrations may involve the valve apparatus, myocardium, pericardium, blood, chest wall, everything has been implicated. So as the valve leaflets close, there is a sudden deceleration of blood flow, and this is causing the surrounding structures to vibrate, and hence we are hearing the sounds. With regard to the first sound, the most important aspect that we make out is its intensity. Is it normal, loud, or feeble? It's heard over the apex beat. It's heard with the diaphragm. The intensity of the first sound, to appreciate it, I always draw the comparison with a door and how you close it. Think of a sturdy, rigid door being closed by a young person with a lot of strength in his arm. You hear a loud sound. Think of a weak arm closing it. Think of a squeaky old door closing it. You will get a dull sound. Extend this simile to the mitral valve and you would appreciate what's happening. The integrity of the valve apparatus, meaning a calcific or fibrous valve versus a normal young pliable valve. The normal young pliable valve will produce a loud first sound, whereas an old creaky valve will produce a dull first sound. Where the valve leaflets are situated at the end of diastole. See, if the door is wide open when you're closing it, you're going to slam it shut and the sound will be loud. If the door is already nearly closed when you start closing it, the sound will be dull. So if the mitral valve leaflets are far apart when you are beginning to close, the sound will be loud. If they are nearly closed when the closure starts, the sound will be dull. Then we drew the comparison with the strength of the arm that is closing the door. A strong arm and a young arm produces a loud sound. The equivalent in the heart is the rate of rise of left ventricular pressure. It is a rise in the LV pressure which causes the mitral valve leaflets to close. So if the rate of rise of pressure is slow, what you get is a dull sound, as would happen in a myocarditis or myocardial infarction. The PR interval would be the determinant of where the mitral valve leaflets are at the end of diastole. In other words, if the atrium has not contracted, the leaflets are fairly far apart. If the atrium is contracting, when the leaflets are close together, close to the closing position, then you are likely to get a loud first sound. So the loud S1 could occur in mitral stenosis because the LA pressure is high, the leaflets are far apart when the closure is happening. Tachycardia, because there is little time for the valve leaflets to close. Short PR interval, because the atrium is contracting when leaflets are far apart. VSD or PDA, because there is a increased flow across the mitral valve. So the valve leaflets are beginning to close later in diastole. These are all causes for a loud S1. The other side of this, the feeble S1, supposing there is an acute mitral regurgitation or acute aortic regurgitation, the rise in LV pressure, the LV end diastolic pressure, pushes the valve leaflets up. So the closure is from a near close position. In viral myocarditis, dilated cardiomyopathy, or acute myocardial infarction, the rate of rise of pressure is dull. It could also be extracardiac causes in a very obese child, or if there is a left pleural effusion or a pneumothorax, you're not going to hear the heart sounds well. But there, everything is dull. It's not that S1 alone is dull. Varying intensity of the S1 means the beat 1 has a loud sound, beat 2 has a dull sound, beat 3 is something in between. That's a feature of complete heart block. In complete heart block, as the atrial contractions are dissociated from the ventricular contractions, the actual occurrence of the P wave in relation to the QRS is absolutely variable. And this is the reason why you have a varying intensity of the first sound. Frequent ectopics would do something very similar. Atrial fibrillation would do something very similar. We spoke of the split first sound. Remember, if the split is heard, it means the tricuspid component, which otherwise is not heard, is now audible. And the reason for that could be a complete right bundle branch block or an Epstein's anomaly, or sometimes, rarely, in an ASD or a left ventricular pacing. With regard to the second sound, the most important aspect that we need to make out is splitting. Remember, the splitting is not audible, meaning the second sound is single in the first few days of life. It is by the 5th or 6th day in the neonatal period that the split becomes audible, which means the P2 becomes audible. You know that the neonatal pulmonary vascular resistance is high because the fetal PVR is high and it has to drop. So the PVR to drop to a level to make the P2 audible takes a few days. And why does the splitting occur at all? This is because in inspiration, the right ventricle pumps a much larger volume of blood into the lung. In inspiration, there's a venous return increase into the heart. Therefore, this right ventricle has to pump out a larger volume of blood in inspiration. and therefore the P2 is delayed. The occurrence of the end of systole in right ventricle is later, which is to say that P2 is delayed. In addition, there is a different mechanism which is related to the pulmonary vascular resistance and the hangout interval. I'll go back to our original diagram. If you see this picture, I said this is a picture for the left ventricle, but this is equally applicable to the right ventricle. All that matters is that the pressures are lower. Here in systole, you find that at the end of slow ejection, the pressures in the left ventricle are rapidly declining. And when it is declining, it is crossing the pulmonary artery trace. I told you, I'm presuming that this is now, instead of aorta, imagine this as PA and imagine this as RV. It will look very similar, except that the actual values will be lower. Instead of this 120, it will become 30. Now, when this crossover takes place, in the aortic valve, the A2 occurs at this point where it is marked. A2 will actually occur. But in the right ventricle, it does not occur at a crossover point. In the right ventricle, it will occur only here, an interval after the crossover. Now, why is it that the valve is hanging out after the pressure in the right ventricle has dropped below the pulmonary artery? This is related to the low pulmonary vascular resistance. So the low pulmonary vascular resistance causes a hangout interval, which is significant in the right heart. And that is why the split occurs. So the split is because of two reasons: the increased venous return and the longer hangout interval in the right heart. To appreciate the split, you have to appreciate the P2. Otherwise, you're hearing the A2 everywhere. Over the apex beat, what you're hearing is the A2. Over the aortic area, what you're hearing is the A2. The normal P2 is confined to the pulmonary area. This you hear only in inspiration. You don't ask the child to take a respiration, child to take a deep breath. All that you do is to keep your hand on the child's abdomen and auscultate. Your hand will tell you which phase of respiration the kid is. In inspiration, you will realize that the second sound broadens and becomes two distinct components. The two components will fuse in expiration. This is what would normally happen. And apart from the split itself, you need to look for the intensity of A2 and P2. Normally, the A2 is much louder than the P2. The P2 is confined to the pulmonary area, and P2 is audible only in inspiration. The P2, if it becomes loud, it becomes equal to A2. So the yardstick by which you make the statement that the P2 is loud is by comparing with A2 the way you hear it. If it is as loud as A2, it is loud. Or it could be louder than A2. If it is palpable, it is loud. There are different variants of split that are possible. We speak of a wide split, which means the normal characteristics of the split are retained to the extent that it is wider in inspiration than in expiration. But you can still hear, if you hear the split in expiration, it is much narrower than what you are hearing in inspiration. Or in practical terms, if you make the child stand up, a normal split usually disappears, but a wide split is still audible in inspiration when the child is standing up. And when the split is wide, it happens because either the P2 is delayed or the A2 is occurring early. The delay in P2 can be a mechanical one. Mechanical meaning the RV is taking a longer time to eject. This happens in pulmonary stenosis, in Epstein's anomaly with the dysfunctioning right ventricle, ASD because of the larger volume of blood that is there. This is all mechanical delay. It can be electrical because the onset of activation of the RV is later than normal. In a right bundle branch block, it is the left ventricle which is excited first. Or if you're pacing the left ventricle, it is a left ventricle, obviously, which will get pace first. If you have a WBW syndrome, a pre-excitation pathway which pre-excites the left-sided ventricle first, the RV is getting excited later. In all these instances, the P2 is delayed, and these are electrical reasons for delay in P2. And a wide split due to early A2 can also occur. When you say that P2 is delayed, you are saying that RV takes too long a time to complete its ejection. When you are saying that A2 is early, you are saying RV is okay, but the LV is finishing its ejection much earlier. And when does the LV do that? When it is too smart. When is it too smart? When it has an optimal diastolic stretch, a mild mitral regurgitation, a mild aortic regurgitation, a small VSD. In these instances, the left ventricle is stretched more than usual in diastole, and therefore, as per Starling's law, it contracts much more vigorously, causing the LV to complete its ejection earlier and thereby causing a wider split. We speak of fixed splitting, which is usually characteristic of atrial septal defect. There are a few other conditions like a right ventricular cardiomyopathy, a fixed cardiac output due to congestive heart failure. These reasons can also be a reason for fixed split, but the sine qua non of atrial septal defect is a fixed splitting of the second sound, a wide and fixed split of the second sound. Of this, why it is wide, we have already explained, because RV is ejecting a bigger volume. Why is it fixed? The split is fixed means even though the split is wide, what the RV is ejecting is the same in inspiration and expiration. That is why the split is not varying. Now, why is it that the RV is ejecting the same volume in inspiration and expiration? That is where the ASD physiology comes. In inspiration, the RV should receive a larger volume from the venous return. Fair enough. But then in inspiration, the ASD shunts less as the RA is filled. Therefore, the left to right shunt is less during inspiration. Contrary-wise, in expiration, the venous return is obviously less, but then the left to right shunt is more. As a result, as far as the right ventricle is concerned, it's getting in the same larger volume in inspiration as well as in expiration. So the split is fixed and the split is wide. Wide because of the larger volume, fixed because of the relative constancy of the inflow into the right ventricle. What else can happen to the split? We spoke of the split being wide, the split being fixed. It can also be paradoxical. A paradoxical split means you can't hear the split in inspiration, but you do hear the split in expiration, or the split is wider in expiration. The opposite of reasons causing a wide split can cause a paradoxical split. In electrical causes, if you have the left ventricular activation delayed by one mechanism or other, you will get a paradoxical split. Left bundle branch block, right ventricular pacing, right ventricular pre-excitation, an ectopic beat coming from the right ventricle. In all these, the activation of the left ventricle begins later, and therefore it completes later. So the second sound split is appreciated better in expiration. You can also have this mechanism operating due to a mechanical reason, where the LV is taking a long time to eject, like in severe aortic stenosis or LV dysfunction. So we were speaking of the split so far. Now coming to P2. I said appreciating the second sound means appreciating the split and then appreciating the relative intensity of A2 and P2. A normal P2 is less intense on auscultation compared to A2. A loud P2 is heard in pulmonary hypertension, idiopathic dilatation of the pulmonary artery, atrial septal defect or a thin chest wall. The idea is if the pulmonary artery is large, it comes closer to the chest wall and thereby closer to your diaphragm or bell which you're using for auscultation. And therefore, you hear that P2 well and you call it loud. A loud P2 could signify pulmonary hypertension, but before you conclude that it is due to pulmonary hypertension, think of simple, innocent reasons of pulmonary arterial dilatation also. At the other extreme, a feeble or absent P2 is also a feature of important diseases. In tetralogy, the P2 is characteristically feeble or absent. This is because the pulmonary valve doesn't close in a smart way in tetralogy fellow. For the pulmonary valve to close briskly in response to the drop in RV pressure relative to PA pressure, the pressure in the RV should drop pretty fast. In tetralogy, in the infundibulum, it's a thick fibrosed infundibulum with a low pressure. It's a delayed and hesitant drop in pressure and therefore a delayed and hesitant closure of the pulmonary valve. In addition, remember in tetralogy, the pulmonary valve is small, the aorta is dextroposed and is sort of covering the pulmonary artery and the valve. This prevents the transmission of whatever dull S2 is produced to the auscultating stethoscope. So the delayed and hesitant closure of the pulmonary valve and the dextroposed aorta covering the pulmonary root are the reasons why the second sound is feeble or absent in tetralogy fellow. In severe valvar PS, this can happen also. In pulmonary atresia, there is no valve to produce a sound. And in truncus arteriosus, there is only one sound and there is only one valve. The intensity of A2, we were speaking of intensity of P2 so far. A2 can be loud or dull. A loud A2 is a feature of hypertension, dilated aorta, or the aortic valve is unduly close to the chest wall. An undue proximity of the aorta to the chest wall happens with tetralogy fellow as the aorta is dilated, or transposition as aorta is right and anterior as the anatomic feature of transposition. A feeble A2 in an older person can be due to a calcific aortic valve or a severe aortic regurgitation or simply because there is hypotension. A single second sound is also an abnormality. We are speaking of a split second sound, the variations of the split that can occur. And now we are coming to a single second sound. When the second sound is single, it means the A2 and the P2 are occurring at the same time. They are fused or one of them is missing. The fusion is a feature of Eisenmenger syndrome. The pulmonary vascular resistance in an Eisenmenger syndrome is similar to the systemic vascular resistance. Think of a large VST at the age of 10 years or 20 years. This is what Eisenmenger syndrome is, and there the second sound is single. The absent P2 as a reason for single second sound operates in a tetralogy absent pulmonary valve syndrome or in a pulmonary atresia. An abnormal position of the pulmonary artery being posterior, and therefore you can't hear it, is a feature of transposition. And the absent aortic second sound is a feature of aortic atresia or calcific aortic stenosis. There being only one valve is what you call truncus arteriosus. In congenitally corrected transposition, where the physiology is okay, but the anatomy is abnormal, and the aorta is left and anterior to the pulmonary artery, the aorta is anterior. It is under the chest wall. And therefore, what you hear is what you hear or may feel in the pulmonary area is the A2 because of the abnormal location of the aortic valve in this condition. So with that, we are finishing our thoughts about first sound and second sound and moving to third heart sound. The S3 is a low frequency vibration. It is attributed to the shudder of the ventricular myocardium as it changes from a rapid elongation to a slow elongation in diastole. Like all other sounds, the shudder causes chordopapillary structures and chest wall to vibrate in addition to the heart muscle. And it is these vibrations which are responsible for the sound. What is interesting about the third sound is that completely normal in an young child or an young adult. Such a sound, timing-wise, behavior-wise, what is a marker of normalcy in young adulthood becomes the marker of something ominous, left ventricular failure in an older adult. So any explanation for the third sound should be capable of explaining this discrepancy. Why is it that we are saying that this sound is the marker of an extra smart ventricle in a child and a failing ventricle with a predicted mortality in an adult? The sound itself occurs during diastole for sure when the ventricular muscle is transitioning from the phase of rapid filling to slow filling. When the ventricular cavity is changing from rapid filling to slow filling, the heart muscle is elongating rapidly initially and then elongating later. It is this transition which causes slow filling. And the vibration that occurs during this transition is an intrinsic property of the young heart. So without any abnormality, you can get a third sound because the ventricular muscle vibrates when this transition is occurring. On the other hand, when the ventricular filling pressure is high in heart failure, the flow across the mitral valve and therefore the early filling is at a higher pressure. And this causes the transition from the rapid filling to the slow filling to be more pronounced and cause vibrations of third sound. Or everything else remaining okay, if the flow through the mitral valve is more in diastole, as would happen in a VSD or in a mitral regurgitation, then again you can hear a third sound because the increased flow causes this transition to be more abrupt. So this is how you explain the third heart sound in the normal young heart and also in the failing heart or the heart with an increased transmitral flow. So to recognize whether a third sound is physiological or pathological, we can ask ourselves some questions. What is the age of the patient? If you're dealing with an older child or an young adult and in an otherwise healthy person, you're hearing the sound, it's a physiological third sound. But a pathological third sound could be heard at any age. When it is in an young adult, you attribute it to a property of the myocardium. Whereas in the older person, it is related to high filling pressure or increased flow across the mitral valve. A physiological third sound can't be accompanied by tachycardia or gallop. If it occurs with a gallop, it's more likely pathological. Also, occurrence of an S4, which we will explain shortly, which signifies a stiff ventricle, will not go with an S3. In S3, if it's related to the ventricular myocardium, which is normal, it can't be stiff. And therefore, S3 plus S4 combination is always abnormal. The physiological third sound would tend to disappear with exercise, while the pathological third sound would be augmented by exercise. Presence of a cardiomegaly is a feature of the pathological third sound. And a pathological third sound correlates like an elevated LVEDP, an increased BNP, a low ejection fraction, a chest X-ray showing cardiomegaly and upper lobe vessels, and an ECG showing left atrial enlargement. All these will go with a pathological S3. A fourth heart sound is a low intensity sound due to the shudder of the ventricular myocardium due to late diastolic filling from atrial contraction. So mind you, what is causing the sound is atrial contraction. But the production of the sound is most component of it from the ventricular myocardium. A fourth sound is always pathological, and it means the ventricle is stiff. It has reduced compliance. On the left side, such a situation occurs in hypertension, in hypertrophic cardiomyopathy, or in coarctation of the aorta. On the right side, it can happen with pulmonary hypertension or pulmonary stenosis. Recognizing a fourth sound, what you hear are two sounds in the vicinity of S1. So is it S1, S4, S1, a split first sound, or something else will depend on how we interpret that. Remember, if you're thinking of a split S1, it can be heard only in the tricuspid area. So if you heard something over the apex, you can't call it split first sound. Similarly, if you're thinking of a ejection click, which again we will explain shortly, an S1 ejection click combination will be heard over the apex beat, and the click is sharper and louder without any respiratory variation. And a left-sided S4 is better heard in expiration, a right-sided S4 is better heard in inspiration. So we spoke of S3, S4. Now an opening snap is a high-pitched diastolic sound which is caused by the sudden opening of the valve in mitral stenosis. A pliable valve with the high LA pressure opens up, but there is a restriction on the opening of the valve. As the valve has reached the maximum excursion, it abruptly halts, sets up vibrations, which are best heard with the diaphragm over the apex beat in the left lateral position. And we know that the earlier the opening snap is heard in diastole, the more severe is mitral stenosis. So just like an opening snap, clicks can also be heard. A click may be phasic or constant. An ejection click. An ejection click may be phasic or constant. If phasic click means it is louder in one phase of respiration compared to another. It is louder in expiration compared to inspiration. A constant click means regardless of respiration, the sound has same intensity. So in a phasic ejection click, which is the feature of valvar pulmonary stenosis, what happens is the pulmonary valve domes. It can't open fully. As the pulmonary valve domes and reaches the maximum excursion, it abruptly halts. There is an abrupt deceleration of blood flow, which sets up vibrations, which is the click. Now, there's the interesting physiology that a phasic ejection click happens to be the only right-sided event to be loud in expiration. You know that all other right-sided events are louder in inspiration. But the pulmonary ejection click is louder in expiration. This is because in inspiration, there is too much of blood in the RV, and that can push open the pulmonary valve to a near open position. So the further opening is across a very short distance. That is why the consequent sound, the ejection click, is not prominent. In expiration, as the RV fills less, there is a much greater range of excursion of the pulmonary valve, causing a louder pulmonary ejection click in expiration. And as the severity of PS increases, the click fuses more and more with S1. And so much so, you may not be able to appreciate two sounds. But remember, the first sound has no business to be selectively loud over the pulmonary area. It should be loud in the apex beat. So if it is selectively loud in the pulmonary area, check which phase of respiration it seems to be louder. You will find that it is expiration. And that is the evidence that what you are hearing is an ejection click which is fused with an S1, a feature of severe PS. Now a constant ejection click. We are speaking of a phasic click so far. A constant ejection click is a feature of a bicuspid aortic valve. Why is it constant as against the phasic click of valvar PS? If there is valvar AS, it will remain constant. This is because the ventricular filling is able to influence the position of the valve on the right side because the pressure in the diastole on the pulmonary arterial side is very low. It's maybe 5 millimeters or 10 millimeters. That does not prevent the valve from moving up or down related to ventricular filling. Try that on the left side. You have a diastolic pressure of 80, and that will not allow LV filling changes to influence the position of the aortic valve. You hear a click best over the apex beat and aortic area. It's a loud, sharp sound without respiratory variation. You can also get what looks like constant clicks from a dilated vessel, the aorta, in a hypertension or a dilated pulmonary artery in idiopathic dilatation or pulmonary arterial hypertension. You have multiple clicks in PDA. You have a non-ejection click in mitral valve collapse. You have other sounds like pericardial rub, which is a superficial, leathery, triphasic sound, which happens in pericarditis. With that background, we'll come to murmurs. As I said, listening to a murmur, identifying a murmur are important things, but more often, your diagnosis depends on your appreciation of the setting in which you are seeing the child, using technology like pulse oximetry, feeling the pulses in the lower limbs. These are things which will give you much greater clues to diagnosis than here. Having said that, do listen for murmurs. You look at the murmur, the grade of the murmur, the pitch, character, respiratory variation, conduction. A systolic murmur is considered pansystolic if it extends from S1 to S2. Typical example is a small or moderate sized VSD or mitral regurgitation. You consider it early systolic when it begins with S1 and ends before S2. Like a small muscular VSD where the contracting muscle cuts off the VSD flow in the later part of systole, it's an early systolic murmur. Now, the American physiologists are now using the word S1 coincident murmur to refer to pansystolic and early systolic murmurs together. An ejection systolic murmur begins an interval after S1 and ends before S2. That happens with aortic stenosis and pulmonary stenosis. And late systolic, like in mitral valve prolapse, as the click occurs later in systole, the mitral regurgitation occurs later in systole. Diastolic murmur similarly can be early diastolic, an aortic regurgitation murmur, or a pulmonary hypertension with pulmonary regurgitation murmur, what's called the Graham-Steele murmur. They're early diastolic murmurs, and they begin with the respective component of the second sound. You call it a delayed diastolic sound when the pulmonary regurgitation is due to a abnormality of the pulmonary valve and not with a pulmonary hypertension. We call it a known pulmonary hypertensive PR. Tetralogy repair leaves behind some pulmonary regurgitation. It is non-hypertensive. Tetralogy absent pulmonary valve, non-pulmonary hypertensive, delayed diastolic murmur. A mid-diastolic murmur is what it denotes. It begins an interval after S2 and ends before S1. Mitral stenosis is a mid-diastolic murmur. The flow murmur of MR or VSD is a mid-diastolic murmur. Pre-systolic murmur at the very end of diastole occurs in mitral stenosis. Can also occur in severe aortic regurgitation when you call it the Austin-Flynn murmur. A continuous murmur begins in systole and runs across the A2 into the diastole, typically in PDA. Originally, Levine and Harvey graded only systolic murmurs. Today, American Heart Association grades diastolic murmurs as well, but we will call systolic murmurs in grade 1 to 6 with increasing levels of intensity, grade 1 being heard with extreme difficulty, while grade 6 is audible even with the stethoscope removed from the chest wall. Grade 4 is one when you start appreciating a thrill. You also describe not only the intensity of the murmur, but the pitch and the character of the murmur. In this context, remember that the normal low pitch sound is 25 to 125 cycles per second, typical male sound. The medium pitch sound is 125 to 300 cycles per second, that of an innocent murmur. And the high pitch sound is more than 300 cycles per second, aortic regurgitation or mitral regurgitation. Medium and high are more in the feminine sound nature. When there is a specific character, you speak of an early diastolic blowing murmur of aortic regurgitation, a musical murmur of caudal rupture, a machinery murmur of PDA, or a honking murmur of mitral valve collapse, mitral regurgitation. If you look at some of the common heart sounds that you hear at different ages, immediately after birth, that's as a pediatrician, you received the baby from the obstetrician and you're hearing a murmur. If it's a softer murmur, it is PDA. If it's a harsher murmur, it's an obstructive murmur, which is either aortic stenosis or pulmonary stenosis or tetralogy of Fallot. And if you're hearing a few hours to a few weeks later, it can still be an obstructive lesion. It can still be a PDA, but VSD also comes into the picture. And at this age group, a soft murmur heard in the pulmonary area and lung fields is related to a physiological peripheral pulmonary artery stenosis. By what we mean is the main pulmonary artery versus the branch pulmonary arteries. The branch pulmonary arteries are disproportionately smaller at this age. And this causes a murmur to be produced there. As the baby grows older, this disappears. When you hear a murmur at the 1 to 4 age group, it's more like innocent murmur or an atrial septal defect. A teenager, when you hear a murmur, it could be innocent. It may be a small VSD or an obstructive lesion, and conditions like hypertrophic cardiomyopathy or mitral valve collapse or mitral regurgitation. All these can be the reason for the first appearance of a murmur in a teenage person. This is an illustration of some of the common murmurs. We know that an aortic stenosis is a harsh ejection systolic murmur over the aortic area and carotids. And a mitral regurgitation murmur is a pansystolic blowing murmur. An aortic regurgitation is an early diastolic blowing murmur. A mitral stenotic murmur is a rough MDM with presystolic accentuation. A PDA has a continuous machinery murmur over the pulmonary area. VSD has a pansystolic murmur at the lower left sternal border. Tricuspid regurgitation has a pansystolic blowing murmur at the lower left sternal border. All this. Then you would also appreciate the respiratory variation. Look for the respiratory variation with the right-sided murmurs increasing with inspiration and the left-sided murmurs increasing with expiration. And you know what murmur is heard best where. If you have a murmur in the aortic area, it's aortic stenosis or an aortic flow murmur. If you have a murmur in the pulmonary area, it can be pulmonary stenosis. It can be PDA if it's a continuous murmur, or even a systolic murmur in infants. A diastolic murmur is pulmonary regurgitation. In the tricuspid area, a systolic murmur is TR or VSD. Over the apex beat, a systolic murmur is MR or aortic stenosis. A diastolic murmur is MS. Over the back, if you hear a murmur, it's like coarctation or peripheral pulmonary artery stenosis or pulmonary AV fistula or aortopulmonary collaterals. We use the word conduction when there is selective propagation of a murmur with same or greater intensity. Like aortic stenosis murmur is heard over the carotids with same or greater intensity. And a mitral regurgitation, particularly a rheumatic mitral regurgitation murmur, is well heard over the axilla and back. But remember, major lesions which have an impact on the survival of the child, may not cause any murmur at all. Transposition is not recognized by a murmur. The very fact that a newborn baby on day 1 or day 2 has profound cyanosis and seems comfortable tells you it is TGA, no murmur heard. A tetralogy, ordinarily it produces a murmur, but when it is in trouble, when it is in cyanotic spell, there is no murmur. A TAPVC, usually there is no murmur. Truncus arteriosus may have a short murmur if the truncal valve is abnormal, but it may not have any finding other than a click. In children, innocent murmurs are very common. These can be a vibratory medium pitch murmurs at the lower left sternal border when you call it Still's murmur. It can be a venous hum from the jugulars or the brachiocephalic veins. It can be an ejection systolic murmur in the pulmonary area in a child with a thin chest wall or a straight back. It can be a peripheral pulmonic murmur, as we explained from the pulmonary branches. We use the word bruit when the murmur is heard over extracardiac location. For instance, we speak of a bruit over coarctation of aorta. We speak of a bruit over an obstructed carotid or femoral. You don't have heart sounds for timing there. There is the concept of dynamic auscultation, which I will not go into, not very important in small babies. In older children, to appreciate things like hypertrophic cardiomyopathy or mitral prolapse, this is important. I'm not discussing this as part of this discussion. Thank you. I'll stop there and I would be very happy if you have any questions.